And do you smoke or alcohol? Use alcohol?
Well, I don't drink alcohol, but I smoke for 30 years. But a bit a day. Yeah, a bit a day, not too much.
A bit a day. How many smoking pack?
Yeah. Do you mean how many packs a day?
Yes,
do you mean how many packs a day? Well, 2 packs for 30 years. Yes.
Oh, and do you have any appointment with the doctor, respiratory doctor before?
Well, I have many appointments with my doctor, but because of some some disease that I have had before, but I never call my doctor because of some disease of respiratory system.
So recently have you exposed with any COVID patients?
COVID patient?
Yes.
What are the symptoms of COVID-19 patients? Someone you think that they are suspected for COVID-19?
It's just a risk factor for your. It may cause your symptoms too, but I think it is just a risk factor that I consider.
Surrounding me, some colleagues, some officer worker around me, they have a fever, and sometimes they cough up, but I don't know if they were negative or positive for COVID-19. And actually, I have never been tested for COVID-19, so I don't know.
Okay, now we let to check some.
Sometimes, doctor, sometimes I feel I have nausea and vomiting, and I don't want to eat anything. And so my father, he died from lung cancer. So do you think that I'm gonna have a lung cancer?
I think we need to check some tests to finally diagnose problem. After that, we can have some advice for you. Also, explain the complaint.
So, do you think that will be I will be infected with COVID-19 because as you said before, okay, some people around me, they have some symptoms, maybe and suspected for COVID-19. So I'm really worried about my problem here. And will I be, in ICU soon? So I'm gonna die?
I'm gonna die. Difficult question. Do you have any comment, Dr. Nguyen?
Okay, so for your symptom, Mr. Andrea, I think that it's more likely to be some infection in your lung rather than any cancer. That is consider to your family history. I think is we can check it when we take some tests, some lab tests for your symptom, such as we can take chest X-ray, and let's find out if you have any abnormal. That's all. So, can I summarize summarize your symptom a bit, and you can check it for me? Andrea, 50 years old. You feel weak and have some bad cough from 4 to 5 days ago. You are working as an officer, and from 4 to 5 days ago you have some fever, but it's not affect your daily routine, and you don't measure how high it is. When you have fever, you feel some cold and chill, and you need a blanket to cover your body. Your past medical history you had hypertension, GERD, hypothyroidism and diabetes mellitus, and well controlled with lisinopril and metformin. Did I miss something?
Lisinopril and omeprazole. I mean omeprazole in Vietnamese. In English, is omeprazole.
Okay.
Yes.
Okay, got it. From 3 days ago, you cough and spit out yellowish sputum, but it is just occasionally, and you have runny nose and shortness breath. Sometimes you feel some pressure in your chest, and it gets worse while you cough or do activities. Your colleagues have some of your colleagues have symptoms that similarity with you, that fever, runny nose, and bad cough, but you are never been tested for COVID. You also feel nausea and vomiting too. Your social history that you have smoked 2 packs a day for 15 years, right? And your father died from lung cancer. Did I miss something?
Okay. Are you finished?
Yes, that's the one.
Okay, let me say something. My job is police officer.
Okay.
I'm police officer. Yes.
Okay.
And I smoke 2 packs a day for 30 years, not 50 years.
30 years?
Yes, 30 years.
Okay,
not 50
sorry.
years. Okay. And
okay, I got it.
Okay. And the pressure that I feel like in my chest, it goes away when I lean forward.
Okay.
Yes. And okay, do you have any question for me?
Yes, we want to check your chest X-rays. Can we?
Chest X-rays. I think chest X-rays. After we go to the general meeting, we will show you. This time I don't have some information about chest X-rays, so I think I don't show you about the chest X-rays right now.
Okay, so how about your sputum culture or blood culture? Do you have it?
Well, okay. Now I just have some information about physical exam and some lab tests about CBC and some chemistry tests. Yeah, some chemistry test panel. Yeah, I just have two lab tests, so I can give you. And do you want to know more about some result of physical exam?
Okay, I want to I want to aspirate your lung.
Yeah, my lungs. Some crackles and wheezing are heard in both lungs. Crackles and wheezing.
Okay.
Do you want to know more? Do you want to know more about?
Yes, I want. Your crackles and wheezing just when you inhale or when you exhale.
Actually, both when I inhale and when I exhale. Yeah, during is always there.
Okay, both.
Yes, Dr. Chung, do you want to know more about my physical exam? Do you think that I have some problem in my heart? My heart is has at 1, at 2, no murmurs, but tachycardia.
Can I check your vital signs?
Okay, my vital signs, BP 130/90, pulse 88, respiratory rate 19, temperature 103.5 degrees Fahrenheit, O2 stat 93% at room air.
Okay, got it.
Yeah. Okay, and one information, when I've been taken to the hospital and they measure my HbA1c about 6.5.
6.5.
Yes.
Okay, I got it. HbA1c.
Yes.
6.5. How's your CBC result?
My CBC, well, I have this, most of them are
Is there
normal,
any?
but there's something abnormal in my white blood count, white blood cells. It increased a lot, up to 20.1.
10
yeah,
20 point.
20.1. Yeah, 20.1.
Okay,
Yes.
okay.
And my glucose level, actually I don't know if they measure when I'm hungry or when after eating, but it's about 120 milligram per deciliter. Do you want to know more about my ENT problem?
Yes, I would like if you take. Have you ever take your ENT endoscopy or anything like that?
Yes, and the results are no eye discharge, no ear discharge, and no abnormalities.
Okay, so that's normal.
Yeah, and no abnormal, and rest of the physical exam is normal. But actually, I'm really right now, I feel really exhausted and tired. And do you want to know more about my social history or some my family history?
Yes, you mentioned that your father died from lung cancer. How your mother
Yes.
and your sibling? Do you have any sibling?
Actually, I have no siblings. I'm only child.
Okay.
Yes, and my mother, she passed away because of car accident, and I'm married, but now I'm divorced. I have
Okay.
one daughter, but I don't know if she is where she is right now. And actually, I'm living alone.
Divorced, and you have just only one child, one
Yes,
daughter.
I just have one daughter. Yeah.
Okay.
Do you have another biochemistry like CRB?
Yes. Okay.
CRB.
Bye.
Quickly.
Hello, everyone. I have to bring you guys back because it's time. Your time finished. I extra 5 minutes, but have any group is finished about taking medical history yet?
Yes, but
Yes. Good job.
so quickly.
Quickly. It's more than 30 minutes. Yeah, more than 30 minutes. But like you guys do really well. According, I joined one group and I saw that. So before I start our case today, I want to ask about the SB. Do you have any comment for your doctor first? Any comments? Any like you think is mistake you want to correct? You think like they're doing good? You want to say the compliment? Anything? Just go ahead because they want to listen the feedback from you, direct like that. Yeah.
Okay, I'm gonna first. Okay.
Go ahead.
For two doctors, they are talking to me, and I actually they're doing quite good, but I'm gonna give them some comments for them to to practice better. And the first thing is they first to ask the question, but the same have the mnemonic. Yeah, I think mnemonic to help them to remember what they ask, and how are the they asked me about one step, but just one question, and then they just move to some other quality, but just they miss some information, and then and I think we just have order. There is something or help them to remember what they should ask, and have a note that helps them what is it complete or is it full, and you wanna oh my god actually I don't know what I'm not but what I mean is they should practice before they go to the meeting, and they should have a note with some question that they should ask the SP, and then they will help them that is it full, is this enough to talk to SP, to ask SP about their problem. And when the SPs ask them about some question, I think some formulas to help them to react the SP or the real patients. The first they say that I know about your problem, and the second is they should tell that I can only imagine what you are feeling right now, and we are here to help you, and we try our best to help you. And I think finally they should give them some offer, just like that we try our best to help you, and we need more information to diagnose what's problem, and after that we will help you a lot, or anything like that.
Thank you so much. So to a doctor belong to the I think this is room 1. So do you listen the feedback from Dr. Thuong? Because I recognize she's encouraged you a lot to ask a question, and also remember about what you miss, because I joined in that room as well, so I recognize you guys become cannot arrange what you already asked, what you need to ask, and sometimes you miss a lot of information, especially here see about the family history, social history, and sexual history. That's also the part of the when you want to take the case, want to ask information, you need to know about that, so don't miss that. You because you cannot arrange well, so the reason why you miss. Any another feedback from another room, even live from the doctor as well? I want to listen from you.
I think my doctor is a good, but I think they should arrange their questions. It will be with some.
So arrange the questions. Any another idea for that? A lot of things. Like who suggests we can have the mnemonic, and according to the first lesson I give you guys about the first lesson, and I also ask you guys divide your paper into 4 parts, and you prepare that first. That's the first part you want to ask, which is the second part, and the next part, and the last part. And in every part you prepare the group of question, should be the mnemonic, very short, and you can remember in next time. You keep that because we have 8 Casetalk for you guys practice, so use it every time you go with us, every time, because you will learn, you will remember, And if you keep like the frame, it's easily for you to remember it next time. And when you finish the oral check, you can check it by yourself. It means you collect a lot of knowledge from that. All right. So my advice for you, so should bring the paper and divide the part of the paper into 4 parts. Put a question in there, and you will not miss it. I guarantee. And you also save your time. Save your time because 30 minutes is a lot to ask a question. For some kind of doctor, they just need to, they ask really quickly, one by one, really quickly. And the second thing, like who said, when you communicate with the patient, you need to build a doctor-patient relationship. So it means you listen to them. It's not like you just like, you are, I know sometimes you feel worried, you feel like nervous, and you cannot performance, but try be calm and like confident and ask a question with don't need to ask a lot, but every question you need to be clear and should be like listen. I mean, like you ask them and you also need to listen to them by using some kind of, we call like pardon words like yes, I understand, okay, I got that, I can feel that, I see that. You see, so patient feel like you listen to them more, and they can easily to share with you more about their symptom as well. So don't forget that. I recognize from my room, I didn't see that yet. And the last thing about the challenge question when the patient asks you guys, so don't be freaking out, because like that's a very simple question. Just like they ask you, can I get the cancer because my father, my mother have that, or can I have the COVID-19? So just say, I know you worry about just your disease. I know like you are not well now. So we are trying to do some tests to recognize what happened to you or give you the diagnosis, and then we can make conclude like what's your disease, and we will give treatment for you, and we are here for you. We will try our best to help you. So that means they build a trust for them. So don't say, no, you didn't get the COVID-19, you cannot get the cancer. I think this is really difficult for you. Who knows? When you make the test, patient get cancer, they will sue you, So don't say it's anything to fight you in legal things. Yeah. And I recognize in the room 1, I see like Dr. Ang, right? Ang Nguyen. She's have a really good part. She make the sample closer. Do you know about sample closer? It means like you summarize what you ask about a patient, what you collect information, what the symptom patient have. It means from like your information you get from the patient, and you arrange that, and you speak again like, yeah, I ask you, I have some kind of symptom like that. Do you think I have something missed, or do you have anything you want to add? That's a really good question, because patient will let you know what you miss. So that's also the important point when you ask lots of questions. You ask about medical history, about past medical history, social history. After that, you summarize. We call this sample closer, right? We can't name for here. We call this sample closer. And actually, for some kind of doctor in the future, in the next time, if you have more time, you can use we call this a patient consent. It means like you give some medical advice according to their kind of bad habit, like smoking, drinking, using like illicit drugs. Provide the patient with the we call it patient consent or counseling. Yes, you can use with that. All right, but I believe you guys complete this really well based on your knowledge at the moment. That's also very good effort. Do you have anything you want to let me know about this?
Yes, I have one comment.
All right, go ahead.
Yes, it's really good when you have a sample closure, But I think you need to summarize or clarify information in a smaller part. For example, after you take some information about social history of patient, you need to clarify, because if you go any further and the story is longer, and sometimes you are easier to meet information, and the patient sometimes they don't remember very well. So I think when you complete smaller parts such as social history or family history, I think you should clarify the information before you go any further by some sample questions, some sample or some sentence like that. Before we go any further, I want to make sure that I really understand what you're telling me. What I'm hearing is decent. So when I'm finished, would you correct me if I did not get it right?
Yeah.
Like that.
It's really good point. So I totally agree with Hương. Good Dr. Hương, she's give the very important points that every information you get from the patient, you need to clarify. So is it correct? Because sometimes you cannot listen well what the patient speak. So you should ask them again by some like user question. But now I see like the doctor asks you a lot, the patient asks you more, because the patient know more about that, so patient ask you more. But you need to clarify about the information patient give you. If you feel like it's still confused, still not clear enough, to ask them again, because if you go further about information you have, you will be like go the wrong pathway. You maybe make the wrong diagnosis as well. Who knows? So yeah, be careful step by step. So about the last thing I want to talk about this here is about the lab test. We make the deal before, so I want you guys take the medical history first, past medical history, social history, all of this, and you ask about like the review system, right? And for the lab test, I think you can keep that until we come to the main section here, and we will discuss with the host, because I will provide the lab test for you according anything you ask. Like, I want to ask you like what the test you want to order for the patient. You can list, and then I'll give you the results. Okay, so we make the deal from today, and the next time we will do like that, because the patient will save time to let you know about the lab test, because I will show you on the slide, so don't worry about it. All right, so that's the last thing I want to give. Okay, so go to our case today, and we'll say what we. So please check with the information you got. Sorry. Yeah, I make it better. So today's case 4. So let's see. Or the symptom of patient here. I don't know how can I become smaller. Can you see it's a whole screen, or is it something like get high behind?
It's so small.
Small? Oh, I use a maximum size. So small?
No, I think I can see it's a full screen now.
I think that is a full screen.
I think it's
You can
okay.
just adjust the screen to put it.
We have chief complaint here. So this is a 50 years old female police officer. Have chief complaints. This have some bad cough, because sometimes I have external patient. You guys say it's a cough or cold. Cough and cold totally different about the meaning. Cough and this I don't feel good. She just described that one day she came home from work. She did not feel good, and she developed a cough the day after that. She also felt pressure in her chest. Don't forget that, and it made her weak. All of this started suddenly. The onset 5 days ago, she didn't feeling good, and then she had a cough one day after. Provocation, it starts suddenly, nothing really triggered it. Palliative symptom, nothing make it better. The pressure feelings just go away. If I learning forward, I learn forward, lean forward. Sorry, I lean forward. You know that, right? What the meaning? Because some kind of is a symptom happen when a patient have symptom, especially pleuritis, chest pain or pleuritis. Pleuritis, chest pain. It will be differential diagnosis with the chest pain belong to the heart. Some kind of like maybe can be in the heart, but like some inflammation belong to the like the layer like peripheral or even like the pleural. So this is symptom for that. Quality, this is how bad it is. That's very, I recognize some doctor ask about this, very bad, and this I feel sometimes I can't breathe. Radiation, pressure, feeling chest do not radiate anywhere. Thumbing, the cough is always there, the pressure is always there. Associated symptom, I have some nausea, vomiting. I occasionally cough out some yellowish sputum. I also do not feel like eating anything. I also feel very weak and have no energy. Alright, so this is kind of quickly for that. Sorry. So past medical history, we have like significant like hypertension, diabetes mellitus, hypothyroidism. Do you collect all this? Medication, we have all the medication here. You can see that. Or even allergies, some fight drugs, antibiotics. Do anyone ask about the Stevens-Johnson syndrome? Or you guys get information about this? The Stevens-Johnson syndrome. Surgery, we have the appendectomy 2 years ago, and the hospitalized, I think the patient have 1 or 2, according to the symptom here. Alright, also history smoking tobacco day for 30 years ago. 30 years, it means 60 pack year. No alcohol, no illicit drugs, divorce. Lived by herself, children left her, felt depressed. Have anyone asked about this? Yep. Police officer, it's a her job. Social history, father died from lung cancer. Mother the case is mean like disease, it mean like death, from car accident. One daughter, no idea where she goes, means she living alone. No siblings. Alright. Review system, fever, chills, shortness of breath, cough and chest pain. The chest pain between when leaning forward. That's very important. Does not radiate anywhere. The rest of the review system, no abnormalities. Examination, I think I will point out some kind of like the positive symptoms. Patient lay on the bed and feeling weak and significant distress. It means she's tired. The lung have crackles and wheezing, hurt on both lungs, and the rest of physical examination is the normal. Alright, so can you guys list for me what the workup you want to order for this patient first? On the inbox, the box chest. Yep. List the lab test you want to order from this patient, and I will provide the result based on this. Alright, you have 1 minute to list the lab test you want to order from the patient. What you want to looking for, what you want to know from the patient to give you the diagnosis. That's very important, you know. And then I will provide the result. If anything I don't have result, I will say this I don't have. Yeah, text here. Yes, chest ray, CBC, we can consider CBC, C-reactive protein, CRP, right, serum chemistry, THH, T3, T4, I mean like thyroid function test, right? ABG, tuberculosis test, blood culture, sputum culture, antibiogram, and TB test. So, alright. So I provide 1 by 1, and some like something repeated, I will not. Yeah. Alright, we'll see. Chemistry, yep. Thyroid function, CRP, urinalysis, chest X-ray, sputum culture, no blood culture. Alright, let's start with the lab test CBC. So you can see here it's a little bit blurred, but I believe you can see that, right? So the CBC see what abnormal. Sorry, I go with the what abnormal from CBC. Every time I have to change the screen. What we call for that? No answer. So you see like patient have like increase white blood cell count. So what we have the name for that? We call like leukocytosis, right? Patient have leukocytosis. Patient with the predominant neutrophil, because we see like the neutrophil level is the increase. It's mean compared to the others. Yeah, we call this the name with the leukocytosis. Yes, correct. And we need to differentiate between two words. This is leukocytosis and leukemia. For leukocytosis, it may increase the number of white blood cell count abnormal. It's a bit maybe from the infection or kind of like reaction or inflammation. For leukemia, it means like also increase the number of white blood cell count, but like this increase not only about the number but also about the size, and also have a lot of abnormal WBC, and this we call this a cancer, white blood cell count cancer. Sorry, white blood cell cancer. The type of the cancer, leukemia, it's totally different about the two names. Correct. So we see from the labs CMP. What you see from here? What you see?
I see something abnormal in glucose level, but I'm confused that is the glucose level, fasting glucose level or after eating glucose level?
Good question. So usually when they give the glucose level like that in the lab test, they will this the fasting glucose levels, or they can take like very random. They didn't use it after you take like we drink the glucose. We call like glucose a lot tolerant test. After you take glucose like 7.5 gram, right? I don't remember exactly. That's usually test for the pregnancy women. So you suspect patient have like diabetes pregnancy, diabetic pregnancy.
Well, I think glucose level in this table, it is the random glucose level.
Yep.
Yes, because the patient she went to the hospital, and I think they will draw some blood from her, and I think it is random glucose level.
Yep.
And the patient was diagnosed with diabetes mellitus and take some medicine to control her disease.
So what do you think from here?
Yeah. So I wonder some information about HbA1c, HbA1c.
Sorry?
Yeah, I want to the result of HbA1c. I mean HbA1c to
Yes.
to
order. You order HbA1c. Correct.
Yes.
When you see like that, first you need to work on like clinical practice. Don't need to work like theory here. You see the result like that. So you need to ask the patient again what the medication you are using. Do you take it regularly? So you need to ask again, like, is it the medication is enough for the patient? Because you see patient take medication while the blood glucose cannot control, like uncontrolled. So for further test, you want to make sure like the patient have like uncontrolled blood glucose. You can go with the HbA1c. That's the more like we call more correct. It's mean high specific value to make the diagnosis for the patient. Because sometimes for random glucose it can be false positive. In some case we don't know. So maybe patient just take food, kind of like that, some sweet food. We don't know, so we need to do HbA1c for a more specific test. Yes, order. You also need to check about the patient using medication. Is it like follow the we call like compliance? Compliance about the prescription from doctor. Or if still when you do the HbA1c and the results still increase, so you need to ask the patient take medication regularly in few days. You still see the patient is not like controlled blood glucose. So what you will do next? That's a clinical practice.
Oh, okay. Well, when if HbA1c is not in the normal level, it is not expected level for the patients. So now if the glucose it is too high, I just use some insulin intravenous IV line. Yeah, I mean intravenous to control the glucose level right now in the hospital. And after the patient they recover from the disease, the problem right now, I just refer them to the some doctor who are specialized in diabetes and give them some advice to control his diabetes.
Okay, how about yours? Any another idea for that?
Yeah, I think when the patient goes to the hospital, it has two situations. Maybe there is something before, and maybe they hungry and they take a blood test. So I think when we take a blood test, if glucose is high, we will ask some questions about the medication, and we focus about the white blood cell than before, because your check complaint is not about the diabetes. We can make the blood test again. If it's still high, we will test HbA1c.
How many times you do for blood test again?
I think it's two times. The first time when they go to the hospital, if the glucose is too high, we will make it again to make sure.
Oh, so you wait how long for the second time?
I think when they go to the hospital, and they will take it when they hungry.
I mean, like what you take the first time they admit to the hospital, right? That's the first time. The next time when? After how many days or how long?
I think maybe 7 days.
7 days. Oh, it's a lot. Because you see the number, the range of the blood glucose patient is quite high. And if you wait until that, I think it's not good for them, especially when they become like some complication of hyperglycemia, like coma, or they can affect some kind of organs. We call end of organs. So kind of like, for me, I will not wait. I will do the together. If the patient 3 months ago, they didn't do any HbA1c test first. They didn't do any HbA1c test 3 months ago. I mean, for the result changing for HbA1c, they need 3 months for changing. So in 3 months, they didn't do any test. I will do for them when together with blood glucose as well, or even like after you see that, you can do, because like it's a save your time. And also like for HbA1c, in the most of the hospital they have this, and it's not quite cheap, so don't need to wait, or then kind of like it's not affect, it's not harmful as well. So you can do it and check it, because it's more specific value, and you can make conclusions based on that. So if still high, for me, I will not give the insulin direct, to be honest, because like if you give the patient insulin now, patient will depends on insulin next time. You cannot stop, you cannot reverse. You know, that's the rule. When you prescribe for the patient, you insulin in the patient, diabetes patient, then you insulin, inject insulin, it means you cannot reverse to the medication. So if the patient use only one medication, you can think about combine two medication, or you can increase the dose of the blood glucose, the medication, or you also ask the patient about like, do they compliance about taking medication, meaning like follow the rule. If they do something wrong, you can give the patient advice. Or if you see the patient didn't have the good diet, good diet in taking a lot of sweet food, a lot of carbohydrate food, they make like their blood glucose cannot control. You can combine lots of things together. After 1 month, you can evaluate again. It still cannot control. You see what happened here? Maybe the patient, what we call like insulin resistant, like you cannot give medication anymore, you need to give the injection, or have some indicate for the level of the the blood glucose are quite high. I mean HbA1c more than, I don't remember exactly, maybe the more than 15, kind of like that. You will direct indicate the patient with the insulin injection, no hesitation. But you can see here, this patient still like the level of glucose is quite high, but you can give more medication or increase the dose. I check a lot of things beside that. Don't give the insulin first, because you cannot reverse. Patient will depend on insulin for the rest of her life.
Well, okay, you made a good point, but what I mean here is if the glucose level of the patient is too high, and it is suggestive for hyperglycemia. I mean, to complication of too much glucose in blood, we should give insulin. But I mean, if the glucose level is too high and it is diagnosed, and it will be diagnosed with two complication of too much glucose in blood. So we should give insulin in the short term, because glucose level, it is affected by many factors, by some disease, by some stress. I don't know exactly what is the level of glucose level for the doctor to diagnose hyperglycemia. Actually, I don't remember exactly number, but the patient 220 milligram, actually it is not too high to diagnose hypoglycemia. So in the patient, actually, I think the most important thing here is it is diagnosed what's the problem, and the glucose after the patient recover from the disease. For example, like the patient is something abnormal in respiratory system, we will confirm the glucose level and it be A1C once again, and after that we should give the best treatment for the patient.
Okay, thank you for your idea. Got that. It's also the idea for that. All right, so for blood glucose, if you cannot like control by yourself as a SB, it means like GB. If you are GB, you just like general practitioner, so you cannot control that well. You can transfer patient to the endocrinologist, right? Kind of like some specialists, they work with the diabetic specialist. So you will let them to have the patient. That's also the choice. So that's a very challenging treatment, I know, for every doctor. Sometimes it's really hard. Go with the chest X-ray. So what you will see from the chest X-ray here, according to your knowledge or your vocabulary about describe the chest X-ray of the patient, what you see? I want to listen from you guys. Any text for me? Any like?
I see some focal increased density that are both in two lungs. Focal increased density.
All right.
In two lungs.
Or maybe you can say that's diffuse hyperdensity. I said also diffuse density. What else? We should have some vocabularies, as I told you guys before, when you describe some kind of X-ray result. So especially for this patient here. I saw many texts here. I don't know, it's right English. Okay. I suggest, all right, I will provide for that, just simple. But if you want to learn about some vocabulary, medical term belong to the radiography, you can go with the website whom you can provide for them. You say radiopedia.com, and you can read some kind of case in there, and they write very detailed about how you describe the X-ray, even CT scan, even like about MRI. So this you can learn from that, because we are not a radiologist. So, but I can provide some kind of description for you about this X-ray, the patient X-ray. So look at here. Yes, like Dr. Hu said, we have some diffuse hyperdensity and also have reticulopathy. Reticulopathy means like this is kind of you see this is here like the lungs area, and you put the glass and it's become like blur. You cannot see the clear inside, and you see like kind of like reticulopathy, and also we can say this glass. What we call for that, like glass round, and also we can have like infiltrate. This usually description for describe for kind of pneumonia, infiltrate, consolidation. Consolidation for the local pneumonia more than like kind of it's a diffuse like that. Diffuse reticulopathy, that's usually with the subintestinal pneumonia, intestinal pneumonia, and intestinal pneumonia, yes. And also like sometimes they can bring kind of like air fluid area if you have like some abscess. So infiltrate is mean like they have some, you see, it's not like the same density, the same level of the lung parenchyma here. It may have some inflammation, some infection. It affect the lung parenchyma. Parenchyma is pneumophore. Alright, so beside that, for all of the like the heart, we call it COH, COH, and so like aortic, nothing normal here, just like for the lung we can see. So the lung very bad, actually. That's really, really critical. You see the X-ray. You can Google about this and about those of the vocabularies. All right. It's also have a CT scan here. Have CT scan here, and you can see we also have that CT scan. Just log chest here. Infiltrate. Yeah, correct. Good. Thank you for that. And this we have the chest scan, and you can see in here the present of the interstitial parenchyma or pneumonia. And because you see some increase density of the lung parenchyma here, or even like that's really bad, you can see have some lesion and look like this it's not like it's an infiltrate, and you also have some kind of mixture in here and also in here as well. It's not the same density. Yeah, it's also the CT scan for the lung for the case like that. All right, go ahead with the thing we missed. What else you guys want to ask? For CRP, we don't have the results. For the blood culture or sputum culture, we don't have. I wish we have, but like the patient didn't do it yet. What else? For the ABG, we also don't have. So I also provide for you guys 3 lab tests here. So can you make that any diagnosis with that? Any differential diagnosis in your mind for this patient? Yeah. Just think about this. That's this is your patient, your doctor.
Okay.
Yeah.
For my differential diagnosis, I have from the the physical examination, I guess that she could have pneumonia, which I guess is bacterial pneumonia.
Bacterial pneumonia. Okay.
And also I and also I have like COVID-19.
Okay.
in tuberculosis. But after seeing the chest X-ray, I guess that this diagnosis is not right anymore.
Yeah.
And I also have like lung cancer. Kind of.
So you have, I want to like arrange that. This is a pneumonia, like bacterial pneumonia. Second, this is lung, the COVID-19 infection, a positive, or the last thing is about the lung cancer, right?
Yeah.
All right. Anything else? Any other differential diagnosis you want to give add on? How about the others? I just like said, like you guys have me list 3 of differential diagnosis you think in your mind. Which is the most, which is the second, and which is the third? Because that is really important. That's your patient. You need to make a diagnosis and you give the treatment for them, and you need to cure them. Metastatic cancer. All right. Okay, you guys spend time to list for me before I. Thank you for so much for who just speak for me. Who is that? Sorry, I didn't see you. There's a lot of people here. Thảo, right? Yeah, thank you so much, Thảo, because as I and you guys also, you help me to lead that. Anyone here? So I will keep that, and before that I will move to the next slide. That's also important, and I don't know in here any doctor asked about this yet, because patient complain like she will weak all the time. She also like quite depressed, and she's living alone, and she don't have any family support, social support, and what else? What I forgot? Kind of like your patient seem like she have depressed mood, and she also decreased appetite, right? And she also don't feel well. And for me, if I recognize that, I will ask more the question about the depressed or psychiatric question, a couple of questions about the depression, because I want to rule out. If the patient have that, the patient can increase the rate of suicide, or even like hurt themselves, or even they also cannot commitment for treatment. So you need to make diagnosis as well. So I want to leave you guys here about this a couple of questions about the depression. You can use with that, like you can ask them about the appetite. Has your appetite changed lately or recently? Has your weight changed recently? Has there been any change in your sleeping habits lately? Do you enjoy any hobbies? Have you ever thought about hurting yourself or others? Do you think of killing yourself or ending your own life? Do you have any plan to end your life? Or have you lost any interest in your social activities or relationship? You feel hopeless. They feel hopeless, yeah, because they feel worthless, hopeless. Do you feel guilty about anything? This is also kind of a symptom for depressive patient. How's your energy level? Decrease the energy. They feel tired all the time. You don't want to work anything. Can you still perform your daily function or activities? Because some patients, they will daily function or work impairment. Là nó mất cái chức năng công việc. How do you live with? Because we also care about the supportive environment. Do you have any problem in your job? How your performance in your job? We also need to know about that. I think in general, I didn't say for this case. You can list again or short again about the question is important you can want to ask. Have you had any reason, emotional or financial problems? Because we want to care about any critical or stress in their life. Or do you have any reason, traumatic events in your family? You see, so you can use a couple of questions. All right, you can spend time to like capture the what we call this, cap the screen, take a picture of the screen, and you can spend time to revise this when you have time. All right, and it's here as well. All right, yeah. Or otherwise, I can provide you about the article or this document on the Facebook. Don't worry about that. All right, so. Is the question assessment. So let me see here how many people give me about the diagnosis, the differential diagnosis. Paragonism. cerebral pneumonia. So I don't think about this. All right, we have the same here: pneumonia, 2 COVID-19 infection, 3 lung cancer, pneumonia by Staphylococcus aureus. Wow, interesting. I will help you to understand clearly about when we give that. Tuberculosis, good, also a good choice. Lung cancer, not tolerant diabetes medication. Wow, I don't think like medication with the diabetic medication can bring kind of symptom related to the lung like that. Or you think the patient will decrease the immunity? Yeah, also the good. I will explain about this as well. Depression. Yep. For depression, it's a complicated too, because if you want to make a diagnosis for the depression, you need to reach to the DSM-5 criteria, make a diagnosis with the psychiatric disease. For depression, you need have 5 over 9 symptoms, kind of like related to your appetite, your energy, your mood, your suicide term, your level of what do you call the guilty, you want to like quit your job, a lot of things like that. You have the table of the symptom, and you need to have 5 over 9 kind of symptom, and you make diagnosis of depression. Lung cancer, all right, bacteria, pneumonia, lung cancer, metastatic cancer from another cancer market. I will explain. Here's a amount of information, and it's in this case I like 30 minutes asking not enough. Yes, I will explain that after our talk today. COPD, super infection, influenza and pneumonia. Influenza means virus. All right, so interesting. First, I want to confront the patient. That's for you guys. The patient have pneumonia, based on the lab test, based on the symptoms, and you can see very clear patient have pneumonia. But for pneumonia, you need to make different differentiate between like what type of pneumonia patient have. This can be typical pneumonia or atypical pneumonia, and after that you can suspect what is the organism. Besides that, they also divide type pneumonia based on their anatomy. This can be like pneumonia, what we call broncho. We call for that. They can be like bronchoalveolar. That should be the name. No, it's not like influenza. That should be like that have the infection with the bronchi and also bronchial, and also like for the pneumonia. So I forgot the name for that. Anyone can help me with that. And another thing, this can be like local pneumonia. Local pneumonia is divided based on the anatomy. So they have many ways to divide. It also have like acquired, what we call for that, like community acquired pneumonia, and this also healthcare associated pneumonia or hospitalized acquired pneumonia. That's a lot of classification they can divide for the patient with the pneumonia. So look at the patient here. I suspect because we need to do the blood culture or even sputum culture to target this is what is the organism. But I think the patient have the atypical pneumonia, and that should be like one type of bacteria in here for atypical pneumonia. For divide typical and atypical, who can help me to differentiate between atypical and typical pneumonia? I know somebody here, they learn about this. How different between that? Hello? How different between like typical and atypical pneumonia? Look at the symptom of the patient here. Yes, bronchopneumonia, correct. Bronchopneumonia, I want to talk about this. viêm quản phổi. Yeah. All right, so we have typical and atypical pneumonia. So you just need to learn, look like this is typical and atypical angina, kind of like that. Yeah, typical and atypical angina. And it also have the typical and atypical pneumonia. So for typical, it means they have all of the symptoms of the patient who would be infected from like bacteria in here. So they can have like high fever, can have like sputum, like we call this the productive cough. They can have like infection appearance, and they, when you do the examination for the lungs, we can have some crackles or some like abnormal. When you do consult the what we call percussion, or even do lung examination, you can see some abnormal crackles or some round in there. Yes, productive cough. So, and the patient present very clear symptom of infectious disease. For atypical pneumonia, patient have pneumonia. Patient also get from bacteria, but the symptom is not clear enough. And sometimes you look like the patient get the virus infection. You know, virus is not bacteria. Virus, the symptom that look like flu-like symptom. Patient get tired, like they have the muscle pain. They have like, can be dry cough or like productive cough. Patient can have low fever, or just sometimes don't have fever as well. Just like have symptom of like lung, we call them pulmonary symptoms. And we also, so we need to differentiate between virus pneumonia and atypical pneumonia based on the chest X-ray, right? For this patient, we see like patient don't have much kind of symptom like clear about typical pneumonia, and look at, but kind of like look at the X-ray here. That's really worse. That's really bad. X-ray here, so we cannot think that's a virus. You should think this is a bacteria. All right, and that's the why I think the atypical pneumonia, because when I compare between the symptom of the patient and the result of chest X-ray, I think it's not like equal enough. The chest X-ray look like it's really patient really ill, and they're really severe. But look at the symptom, patient is look kind of like flu-like symptom, or even like virus infection. So it's make me most likely think this is atypical pneumonia. And the most common cause of the atypical pneumonia is the Mycoplasma pneumonia. The most common cause. I didn't say that I do any culture, I may conclude, but the most common, so I suspect is highly suspect this patient have the Mycoplasma pneumonia, sorry. And for the lung cancer, it's okay. I can put this the second differential diagnosis. And for the COVID-19, I cannot exclude as well, because like in this time patient can have this, but can be, it's not like patient will highly think this patient have COVID-19, because for the COVID-19 they start with the symptom is shortness of breath, lost taste, lost smells, right? And their presentation will become so fast. Their lung destroy really fast, and the patient become into the respiratory failure, ARDS, right? So that will be COVID-19 in case patient hospitalized like that. So I will put this third. Lung cancer, because like this patient is, how old is she now? She's 50 years old. That's also like the old patient, and she also like smoking. She also had like family history. Her father died, right, for the lung cancer, and she also presents symptom of like systemic symptom, decreased appetite, that she didn't feeling good. See tiredness all the time, so we cannot exclude as a lung cancer. And look at the chest X-ray, this is also kind of very terrible, so we cannot exclude as well. All right, And here I see one people, the doctor suspect patient have pneumonia with the Staphylococcus aureus, right? Right? So I want to explain like why it's not, why I will not think, I didn't say will not, but I will not think for this case. For pneumonia with the Staphylococcus aureus, the Staphylococcus aureus, they will get infection after the patient get virus. If a virus pneumonia or virus infection or respiratory infection with the virus, even upper or even lower respiratory infection, so they need have like prolonged symptoms, and you see the patient have the period get the virus, because the Staphylococcus, they will get effect in case patient have the virus. The virus will impair the function of the lung protection, especially for the villi, some like some kind of like the air in the mucus. They will detect all this, and that's create a chain for the Staphylococcus aureus coming. It means open the door and please come here. Otherwise, the Staphylococcus aureus bring the pneumonia really rare. Strep, more common. If you give the typical pneumonia, this will be streptococcus pneumonia. You get that, right? Strep is the most common cause. It's not staph. For the TB, I will put that in the last. Differential diagnosis of opportunity infection. All right, for we call like we have two types. This is community, it's not opportunity. Community acquired pneumonia, and this is a hospital acquired pneumonia. We can divide this. It's in case patient like in the hospital or patient outside the hospital, and after 48 hours hospitalization, we can make a diagnosis with the hospital acquired pneumonia. And for the, and you know why? Opportunity pneumonia, I understand. The patient have the diabetes, their immunity decrease. We call like immunosuppression, because patient have diabetes. That's a very important point. And also patient smoking. That's also increase the risk of the opportunity infection. And here is the pneumonia. For the patient who have another infection with the, we call them PCP, neocystic vaccine, PCB infection with the, especially with HIV patient. PCB, this is one kind of fungi. Yeah, PCB, pneumocystic vaccine pneumonia. Good. Pneumocystic pneumonia. I can be, but the symptoms not like that. The X-ray of pneumocystic pneumonia will totally different. You should looking for about that. I will not say this patient will be like that. All right. So, is it any question for me? Because it's also late now. I want to teach you guys a lot, but like, because we don't have much time. Okay, go ahead, Lynn.
I still confused about the pneumonia and COVID, because the evidence of the patient is not clear. I don't know the patient come from. They police officer, maybe they maybe she exposed with the COVID, and some patient has a symptomatic. So yeah. I think in some COVID is mutation, and maybe it's the same similar with the pneumonia. And yeah. I want to do the test for the patient to take the COVID.
Agree. I agree. Sorry, I forgot to bring that. Yes. Besides we make diagnosis, we also like test patient with COVID-19 to make sure they see negative. Who knows when they have positive? So do with the COVID-19 test, and also like do another test with, you should give the patient with the antibiotics directly. And we start with the based on your experience. It means like you suspect patient have Mycoplasma pneumonia, you should give the patient antibiotic, and then you will do the sputum culture or blood culture, and you will see like what specific organism, and you can change or you can continue your medication. All right, so I want to ask you guys, what type of the antibiotic you want to give the patient now? Hello, any suggestion for me? Yes, macrolide, quinolones. All right, see you next 2 weeks. Duyên, yep, thank you so much for quinolone. Right, finish cephalosporin 3. So for me, I will give the patient this macrolide antibiotic, because that's a good have the effect for kind of like we call the upper part of the body, especially for the lungs, for the head and neck, some infection in there. So the macrolide work well, and the macrolide can cover both like negative and positive organism. And the second can be cephalosporin 3, and quinolone can be I will not choose it, or even like the last choice, we'll not choose the penicillin or kind of any another thing, but like macrolide. Next is cephalosporin 3 and quinolone. So some kind of medication, you can take a time to check about the kind of the group of that, and the indication and contraindication, and also side effect, if you think. So I will start with the macrolide. All right, so if I go with the macrolide, what the medication should be? Do you know about any name from like macrolide? Should be like about azithromycin, erythromycin, clarithromycin, and sometime with the aziclaric and that should be enough for macrolide, you can remember. So, and doxycycline as well, fluoroquinolones. Fluoroquinolones is also like the good choice. The next choice with the combined with the macrolide, or even like about cephalosporin 3. But cephalosporin 3 also kind of like in our country is a resistant, increase the risk of resistance recently. And that's it. Any question for me? It's a lot. I know that's a lot always.
Okay, what about the result of thyroid function test?
The thyroid function test, the result. You want to ask about result?
Yes.
Do the patient use it? The patient take it? Where the patient take the result? Thyroid function test? No, the patient didn't take thyroid function test yet. So you want to ask me about like the meaning, or you want to ask me like will we do it, or about only the result?
Oh well, I want to know more about the result.
I'm sorry, didn't do it yet. We don't have result. Should not forget the oxygen. Alright, so for thyroid function test, what you suspect in your mind about the diagnosis or about the symptom patient here?
Okay, in home medicine, I don't see any medicine to control her disease, hypothyroidism. So I suppose the expected result is FT3 or FT4 is in a lower level, and T at 8 would be a high level. Yeah. You
guess if you think patient.
Yeah, I guess. Yeah, I guess.
Hypothyroidism, right?
Yes, I guess. Yeah.
So you need to looking for again about symptoms of hypothyroidism. Hypothyroidism, it should be like patient gain weight. They become like slowly gains weight, cold, decrease heart rate, decrease the breath sound, like kind of like decrease a little bit. They also feel depressed mood, and they also kind of like, go ahead, Wei. Want to say something about that?
No. Hypo. I'm just thinking about depressions is cause of like chronic cause.
Sorry?
Yeah, I'm just thinking about the depressions.
Depression.
Yes, we play the role as a chronic
The depression
cause.
we call like depressed mood, can have in the thyroid hypothyroidism. They can have the depressed mood. I totally agree. But like you need to differentiate between hypothyroidism and depression. Because the depression, you need to, as I told you, they have at least 5 symptoms over the night. Group of criteria of the symptom to make diagnosis, and the symptom you need at least 6 months. More than 6 months, you can make the 6 months or 2 months. 2 weeks. The symptoms should more than 2 weeks. You can make the depression, and you can looking for about some societal kind of like that. For hypothyroidism, they can have depressed mood, but the symptom cannot like have enough to make the diagnosis with depression. And they combine with some like physical symptoms, like I told you, gain weight. They can change in their temperature. They become like afraid about the cold. They feel become like how can I say? They decrease their heart rate, their respiratory rate. They also become slower. They become like their face become kind of like it's not flexible enough. Their appearance kind of like very slow, and they do everything very slow. Even their thinking also slow as well. And you can see that. If you see that, you cannot forget. And this opposite, totally opposite with hypothyroidism. All right. So just that. That also a good point if you suspect patient have like hypothyroidism. But I told you need to looking for more about symptom, and you see the patient have that or not. And you also order for me, I also order thyroid function test, COVID-19 test, and 2 tests I want to check. And I will give the patient treatment, and I will follow up if the symptom improve. And I also do blood culture as well, sputum culture and weight. And this symptom is improve. I mean, like my treatment is correct. If the symptom is not improved much, or like I need to see about what specific organism, or after that I can do the CT scan of the lung and to see like is the patient have the CT scan, okay, and I will should be check the specific organism, get the specific treatment. That's my plan for this case. And also I will manage about the medication for diabetes as well. That's it. And anyone who wants to give more information about that, or you think that's good? I want to listen from you guys. That's my plan for this my patient. I will do like that. What else? I forget. If you think you can help me, if you agree, you need to manage the patient with the whole symptoms. Like you should not go direct jumping to one problem, the whole picture, the whole symptom. Treat the patient, individualize the patient. For one thing here, patient in fact said like we have like should not forget the oxygen supply here, right? This is 93%, and this patient have like short of breath. This is CO2 40. I care about ABG. I forgot ABG. You see, the patient also don't have the ABG yet, so I also go with the ABG, and we'll see the patient have any problem like disorder. We call like electrolyte disturbance, and we can. So I want to ask you guys, will you guys give patient oxygen supplementation with the oxygen level SpO2 like that? Will you? Start with the oxygen supplementation.
Em nghĩ là có thể cho bệnh nhân thở oxy cao áp nếu bệnh nhân có phần trăm oxy là dưới 95% nếu là người bình thường, và dưới 92% nếu là dưới 92% nếu là bị COPD.
Any idea? Thank you so much. Any idea for me? patient looked like very agitation and distress, right? And her oxygen saturation also decreased. 93 from less than 95. The normal range is 95 to 100%. So now this is decreased. And the patient also distress and agitation. For me, if I want to give the oxygen supplementation, okay, I will give, but very low dose. And just like go with the cannula, no hyperrabic, a high oxygen level, no, because they can damage their lungs, her lung. No, just a low dose and give a cannula by the nose, and that's simple. Just because support their respiratory system, and also we can help her keep calm and decrease about distress and agitation. That's my idea. I want to discuss about this because we learn a lot from the patient, from the case. That's a real case. You guys will do it when you go to the hospital, when you do the practice as physician. What will you do? You don't have a time for we can have a time, but you can have to make decision, and you have plan for a treatment. That should be. Sometimes you can make mistake. We admit mistake, but reduce that as much as you can. Don't kill the patient. You need to bring the good treatment for them, the good thing for them. Len, go ahead.
Patient has a symptom of nausea and vomiting. Yeah. So I think how patient use metformin. So is any problem with patient?
Good question. For the metformin medication, when you use it, especially with the long term and in the high dose, they can bring some kind of gastric disturbance or gastric abnormality. Like you feel like flatulent nghĩa là nó không có, nó ốc ách, nó khó tiêu, and discomfort, like abdominal discomfort, and that's a kind of symbol, especially nasal cannula. Yeah, thank you so much. This is especially when you take it without what I can say, with or without food, I don't remember. With food, without food, and you take it and you feel like the patient can complain to you about kind of symptom like that, discomfort. They cannot feel well, but for metformin cannot nausea, vomiting. That's really rare. Nausea, vomiting can become she cough a lot. Maybe this cannot because of diabetes.
So we can change another medication?
No, I will not. Because for the metformin, she's have the good. We will follow up because is it from the medication or not? How can I say? For the side effect, I will not think that's from metformin, like the symptom of vomiting, nausea. But for discomfort, stomach discomfort, I agree, patient that's a metformin side effect or adverse effect. But for the stop metformin, I will not, because patient still control. Until now, we do not know that's it from the medication or from the compliant using medication at home. She's use regularly, or that's from any her diet. We don't know. We need to investigate. So we will not stop metformin till now and change another medication, because the metformin have the good effect treatment, especially if patient have any contraindication or even side effect, severe side effect. We will stop. No, we will not stop here. Yes, Sung will leave here. Anyone? Thank you so much. Anyone for have another question? I wanted to take a picture, but you guys leave a lot. Just souvenir picture. Just open your camera before we stop. I know that's the case. We have lots of things to discuss, but our time also limit the 10th. So let's take a picture before you guys leave. And we can discuss after that because I don't know many people can stay with us. Sorry. Yep. Are you ready? Yes. Just smile. Say smile. Yeah. All right. So we still have one question here. All right. If the patient is still using comeback metformin, no. Patient you have the GERD, maybe she's nausea vomiting after that. I discussed our GERD, nausea vomiting. After that, you need to see patient have symptom GERD now or not. For GERD, they will have burning pain. GERD can bring like vomiting and nausea, vomiting kind of. They have burning pain. They have kind of like discomfort about the chest. I agree. And symptom will be like they cannot consume more food. They don't feel well after they eat the food or any meal, and they feel like after that they will feel like burning pain and kind of. This is not like nausea, vomiting. The nausea, vomiting usually is from like trigger from like you cough a lot, or the other symptom related to the GI symptoms more than GERD or side effect of metformin, as I know from my experience. And the last thing here is about like insulin level come back to the metformin. I would say no. The patient will depends on that. That reason why you need to be very careful when you prescribe for the patient insulin. All right. Wow, a lot. So we will stop today. I wish I have more time for you guys, and I will give lots of my experience based on that. So see you guys next week. And oh my God, I'm sorry, we still have the feedback from the sub note, right? The notes. Do you receive the feedback from the comment? You received that, right? So I want to say that last week we have very good note from one member here. This is Mỹ An, right? You guys, Mỹ An, right? According to the comment from my Dr. Leon. So that's a Mỹ An, very good short note. So I want you guys give that today, and we can give you feedback after that, and we hope you can learn from that. Yes, and after the talk, fill the feedback, the form is SAOP note. Oh, you did not receive any feedback? All right, we will check it. Thảo, right? Yeah. You have anything, you should send an email for us if we miss, because sometimes we miss. Don't worry, we feedback for everyone, sometimes we miss, and just email for us. All right?